Good afternoon, good morning, good evening for some of you even. My name is Jasper Schipperijn and I'm the president of ISPAH, the International Society of Physical Activity and Health. And I would very much like to welcome you to this fourth webinar in the series of webinars that ISPAH is organizing together with the World Health Organization, where we try to look at the science behind the guidelines, new guidelines for physical activity and sedentary behavior that were launched in November 2020. And as I said, this is the fourth webinar in the series. It is this time we will be talking about surveillance on physical activity, new guidelines, new surveillance. We have put together we think, a very exciting program with a lot of very good speakers. You see them here on the slide, who will take you through a series of different issues related to surveillance. And before we go to the speakers, I would like to give the floor to Dr. Fiona Bull from the World Health Organization, who I'll be sharing the moderation with today. Fiona?
Thank you very much, and very good morning, good afternoon, or good evening to everyone joining the webinar. And extend my thanks to the panelists who joined to share their knowledge and expertise with us. I'd like to start by thanking ISPAH again for the series that we're conducting to extend and disseminate the new WHO guidelines on physical activity and sedentary behaviour. And this, as Jasper's just introduced, is the fourth of a series where we've explored how you communicate the guidelines in communication campaigns and dissemination strategies, how the guidelines can help inform practice. Certainly in the promotion to youth is one population group we've covered already, and indeed what the implications of the new sedentary guidelines are. But one of the main purposes of developing guidelines is to inform policy, not just other national policies on physical activity, but policy and practice of surveillance. And so we're very pleased to have this fourth seminar focusing on this topic, because surveillance and measuring is a particularly fundamental part of our work to show progress, to guide and inform practice and improve what we're doing, and of course to show the importance of physical activity, because largely we've seen the trends in physical activity as quite static, with 1 in 4 adults not meeting the recommendations and 4 out of 5 adolescents. Behind that, though, are instruments, science and methods, and our panel is expert in various aspects of that. And what's particularly exciting about this point in time is the opportunity to use some of the new technologies, wearables as we call them. And we're going to hear about some of those. But the challenge for us is how to secure, sustain surveillance of physical activity, adapt and modify according to the new guidelines, but then capitalize on the possibilities of new technologies that need to be affordable and practical. And we're going to hear all about that, but much more detail from our panel. So it's my great pleasure to take us forward into the first panel panelist. And information was just being shown about joining via the Q&A, posting your questions, and of course the chat box. But it's my great pleasure to get us started on a very rich program by introducing Dr. Rick Troiano, who is joining us from the US. And Rick is currently Program Director in the Risk Factor Assessment Branch of the Epidemiology and Genomics Research Program at NCI, in Division of Cancer Control. Rick has studied nutrition originally, and we forgive you for that, Rick, but you saw the light and you have had a career, an extended career, in studying and measuring and advancing the measurement and surveillance of physical activity. You've worked for over 20 years at NCI and in total approaching 30 years in government. And we're absolutely delighted to have your expertise to take us through the implications of the new guidelines, the new global guidelines, particularly because you've been involved in the US guidelines, the 2008 and 2018 US guidelines, and served on the WHO Guideline Development Group. Rick, it's a great pleasure to invite you to take the floor for this international presentation. Thank you, Rick.
Well, thank you, Fiona. And greetings to everyone. It's really a pleasure to be here with you, whatever time of day it is for you. And I'm getting my screen up here. Hopefully, if somebody could let me know in a moment if they're seeing my slides, that'd be great.
Your slides are there, Rick.
Excellent. Okay, so I'm going to provide a bit of an overview about surveillance and guidelines, and then raise some questions about how we need to adopt and adapt surveillance to address the way that the guidelines have changed most recently, and really with a reflection on even a kind of a longer horizon view. So I'll talk a little bit about how the guidelines have evolved, focusing on how reporting is affected. The sort of the meat of the presentation will be the challenges with the new guidelines. And then at the end, I'll finish with some considerations and hopefully some provocative questions to consider. So talking about evolution, going back to the 70s when the first kind of exercise guidelines were created, at that time, the focus was on increasing fitness, and it was about exercise, which was done in sort of different clothes and in a programmed manner. So, that made reporting it pretty easy. When we got to the mid-1990s, we shifted to what we sometimes refer to as the public health paradigm, where rather than just exercise, it was focusing on accumulating moderate to vigorous physical activity. The recommendation was to do about 30 minutes most days of the week, which was operationalized as at least 5 days a week. And we had at that point a recommendation that in order to quote unquote count, it had to occur at least 10 minutes at a time, which, while accumulation is a harder thing to report for respondents, at least we had bouts to make it sort of definable. In the early 2000s, in the US, and then 2010, WHO, other high-income countries adopted physical activity guidelines that stayed with this public health accumulation model. Because the science for a specific frequency wasn't there, the recommendations moved to a weekly volume of 150 to 300 minutes a week. And that I've only highlighted 150 in the top row to remind me, to remind you that WHO guidelines just kind of focused on the low end of that range and just said at least 150 minutes a week. One of the evolutions at that time was to recognize that there was not a magic threshold of minutes or intensities, and some focus on that, some is better than none. So we were, recognizing there's benefits even at levels below the guidelines. And then most recently, 2018 in the US, 2020 with WHO and other, again, high-income countries. The biggest difference is now sedentary behavior was more universally incorporated into the guidelines, to at least to reduce that. So to kind of move more, sit less, move more, sit less. The range stayed pretty much the same. But the huge change at that point was the removal of the bout criterion. And the idea that everything counts, even sporadic bits of physical activity. It hasn't really been incorporated yet, but there was even a hint that even light intensity physical activity had health enhancing benefits. So sort of what we're interested in became a much broader concept, and as I'll discuss, much harder to report. So all of that was really about adults. For youth, the situation is a little simpler in that the guidelines have not really changed that much. And just kind of for context, we'll talk about, I suspect, age ranges more later in this presentation. When I talk about youth, it's usually thinking about school aged, so age 6 to the later teens. I know now that we all know now that we have recommendations for younger children as well. So the recommendations have been fairly consistent for at least 60 minutes a day of MVPA. And that's relatively straightforward. You can just ask questions about on how many days did the young person get at least 60 minutes, and you get a reasonable count of those days. A big change in 2020 with the WHO guidelines, which was, I guess, prefaced by Canada, was to switch from at least 60 minutes a day to at least an average of 60 minutes a day, recognizing that some young athletes in particular might have long workout days, and they don't necessarily need to hit 60 on every day to have sufficient amounts of physical activity. So with that background, let's talk a little bit about the challenges of surveillance. And as I've indicated here, hard just keeps getting harder. So again, to start with a little context, at the top of this slide is the definition of surveillance. And as you'll see, I'll emphasize on the systematic data collection aspect of surveillance. And the goals of surveillance require consistency in several domains. Consistency over time, because a primary goal is to monitor trends and also to detect effects of policy changes. And if you have constantly changing metrics that are going to change your outcome, it's hard to detect those underlying secular trends. Particularly for a setting like the World Health Organization, there's also a desire for consistency across geography because we want to have comparisons both within and across national populations. And as the graphic at the bottom shows, this leads to a constant tug of war between the desire to retain consistency, to not change anything so we can look at secular trends versus evolving science about measurement and recognizing that the way we're measuring something could be better, but then the surveillance folks say, no, we have to maintain it so we can monitor our trends. But clearly the changes in the guidelines, because a key aspect of surveillance is to monitor compliance with the guidelines, kind of push that over toward the evolving science side. So some of the issues with surveillance are the challenges of self-report. There's a lot of error, and that's because quantifying behaviors is really hard. We're asking people to do something that is not very easy for any of us. It requires remembering activities that are inherently not memorable. They're routine activities. When we moved away from that exercise paradigm, we're asking people to quantify things that, just happen every day. Sometimes intentionally, sometimes unintentionally, we force people to do quite complicated calculations in their head because we ask questions about in total, how much do you do, or on average, or what's your usual amount? So, that's some high level integral calculus that we're asking people to do for us. And then we often overlook the idea that there's also the issue of relative versus absolute intensity. We use phrases in our questions like somewhat hard, but then we translate them to metrics that have an absolute intensity of 3 METs or 6 METs and add them all up. I won't talk much about it, but just kind of as a point here to note that we have all kinds of other effects because we're looking across different parts of the age continuum, not to mention the fitness continuum. So depending upon both mental and physical capacity, things like relative, reporting for mental capacity at all, and then what relative intensity looks like for physical capacity, differences in attention with aging, memory loss, and even fitness variations within ages, again, really complicate what we wish were a very precise reporting and are more and more recognized is not the case. So what have the changes in the 2020 WHO guidelines produced as challenges for surveillance? Again, highlighting that the goal of surveillance is systematic data collection. Well, we've removed the bout criterion, and now everything counts, as I put in parentheses, if you can count it. I mean, clearly this is going to perhaps introduce huge challenges for physical activity reporting. Operationally, it's easy enough to just remove that little phrase that we've had in our questionnaires that say, only things that last at least 10 minutes count, but we really don't know what the effect of that will be. Simplistically, you would expect the reports of amounts to go up because more things count. But when we really remove that sort of cognitive boundary of being able to define something, we could get numbers that could go either way, high, low. We just really don't know what we're going to see yet. The range, emphasizing the range is less of a problem, focusing on the 150 to 300, which is recognizing that there are additional benefits beyond 150. That really is possible to monitor with the current questions in the existing surveillance systems. It's just kind of looking at some different quantities. In terms of limiting sedentary behavior in the guidelines, well, that doesn't have a quantitative threshold. So we don't need to talk about that too much other than to make a point that just asking about how much time you spend sitting may not be the best way, because it is possible to be sitting without being sedentary. as is the case for persons with disabilities who use a wheelchair. The guidelines have also emphasized and added other types of physical activity beyond aerobic, which has been a challenge. Historically, we often give short shrift to muscle strengthening activities. We might have a simple question about frequency, but if you read the guidelines, they're focusing on all the major muscle groups, which we pretty much hardly ever ask about. And now we've added a balance measure or balanced behaviors and multi-component physical activity, which further challenge the surveillance systems. And then, as I mentioned, in terms of youth, the shift from at least, which could sort of easily be counted, to on average, means we either need new questions for youth. We can either replace our questions, which would then lose any kind of secular tracking, or perhaps add additional questions that would allow us to move beyond just how many days of at least 60 to get either a total volume or an average weekly amount. I'm not going to talk about this, but just again to put a pin in it, WHO guidelines and others have added several populations that just really are not often included or included in sufficient numbers to make estimates for within surveillance systems. Okay, so one approach to this problem of the challenges of reporting is to say, we now have devices and they will save our butts, but maybe not. And it'll be interesting to hear Andreas's presentation after this, and I'm sure we'll have some discussion. So in terms of removing the bouts, not a problem. We have high resolution time-stamped data. We capture all motion, and so we can look at it bouted or unbouted. We get total volume of movement, so we're all good. We get all sources, not just leisure time, which are historically questionnaires started there. Then we started adding occupational and transportation and household activity, but the guidelines have moved to total activity as the important aspect, and the devices capture all of that. And in terms of quantification and calculation, that's very easy. You can certainly get average minutes, which is actually how Canada has been assessing their youth physical activity based on their device-based national surveys. So within devices broadly, we have both research devices and consumer devices. And so, in terms of research devices, they are already being used in at least national surveys, if not surveillance systems, and in lots of large cohorts. So their use is clearly feasible, at least in high-income countries or countries or settings where resources are sufficient. Clearly in low and middle-income countries, without some external support, the device use could be a challenge. Bigger challenge, I think, broadly, is that in order to do surveillance with devices, we require consensus, and we really don't have that yet for devices. There's lots of different metrics using cut points or other algorithms. There are different wear sites and different devices using proprietary metrics. So we really have a big challenge there still. And furthermore, a single device is not likely to capture all of the aspects of physical activity that we're interested in. And while multiple devices might be better at that, it's just not feasible for surveillance. And I just pointed out some of the types of activity that are a challenge for device-based measures. So what about consumer devices? I'm sure you've all heard that, like, everybody's got wearables. Let's use that data. We can just do surveillance from that. We've got tons of free data out there. Well, I suspect with this audience, that might be true for you and your friends, but not everybody. The global penetration of devices is less than 5%, and it clearly varies tremendously by age and income, and that means it varies a lot by geography. Other challenges are data ownership, both the companies and the users, whether they want to share their data. The fact that you can get a new Fitbit model every year is great for being trendy, but it's a challenge for surveillance because we see constant validation studies with devices, but then that device goes off the market and there's a new device. So that's a challenge for the consistency we're interested in. And then a big problem is that the device manufacturers can change their software. They don't tell anybody about it, and you don't know what the impact is on your metric. So just a couple comments about implications and suggestions. And a provocative question of, is it really time to shake up surveillance? Do we really need to change our model around a little bit here? So these are my personal predictions. I think in the near term, surveillance will continue to rely on self-report. There's just a lot of inertia there, in terms of things are hard to change, and it's what we have, what we can do. Because of the changes in the guidelines, we need to modify questions. There are specific ways that we can do that. And, those of you who work in surveillance know that time and competition for time is a huge challenge. But I hope that what we can do as we transition is to include some bridging studies where in your surveillance system, you include both the new and the old way of asking about the behavior. And then you can get an estimate of, what is the change in method doing to your change in trends. As I've noted, consensus on device data is sorely needed. And we need to think about, not just in moving beyond intensity cut points, because as much as we love them, they're not as good as we thought they were. So we need to think about total acceleration metrics and perhaps more challengingly, moving to develop behavioral versus only intensity classification algorithms, because ultimately it's behavior that we're going to want to intervene on. Longer term, we are in a world where cohorts with devices and longitudinal follow-up, mortality, morbidity follow-up are going to affect our guideline development. And that's what we see with the removal of bouts, the incorporation of light intensity activity. That's going to continue. And my sense is that devices will supplement surveillance and inform guidelines. But in terms of guideline communication and surveillance, we're not likely to go to a 100% device-based solution anytime soon. And so here's my big provocative question. It's really, what should PA surveillance try to measure? We adopted PA surveillance from chronic disease surveillance, and I wonder now if we need to kind of evolve again. So the guidelines are prescribing a total amount of PA and a quantity. Is that what we should try to measure? As I've laid out, there's challenges with that. Should we think about a subset, quantifying a subset of physical activity, which is really kind of what we've been doing historically, just measuring moderate to vigorous physical activity. And respondents might or might not be able to report that reasonably well. This is kind of the big change. Should we think about the presence or absence of easily reported behavioral correlates, and maybe in, a couple of categories, not just a yes/no situation of frequency, of things like that we know affect physical activity quantity, things like active transport, engaging in any kind of purposeful exercise. And I guess the thought to leave you with is to consider, if you cannot measure what you're interested in well, should you measure something else that matters? And I think that's a big question for consideration and discussion. And with that, I'll end and say thank you and move on to our questions.
Rick, outstanding, and a really comprehensive tour there of not just the history from back in the 70s to current day, but also the science, the challenges, the subtleties, and the big steps. But equally, you presented a balanced view right up until the end there, with pros and cons of the different issues that you were raising, and you were on time, so many thanks. Where to start? And I'm going to invite the audience to put some questions there. This could go in two directions in terms of more on the science and picking up on a number of your questions, and we will do, because the panelists are going to expand on several of these. Let me go policy and practice for a moment. You have been integral to the work in the US in its guidelines and its surveillance systems and surveys. I take your last question to us, but just prior to getting to that, what are you doing in the US, given the new US guidelines of 2018? Have you changed your system? Have you held solid because of tracking trends? Are you tinkering, or are you changing a more lock, stock and barrel?
So I think, part of the challenge is that we have, and if I had my CDC colleagues on here, they would have a much clearer answer for what the surveillance system is. But from my perspective, we have multiple surveys that we use for different parts of surveillance, and they are kind of addressing that differently. So I'm pretty sure, and I should have refreshed my memory, in the health interview survey, the recommendation was to just remove the bouts piece. So we basically left the same question, but took out the bout criteria aspect of it. And as I said, I mean, that is certainly consistent with the guidelines. We have pretty much no idea what it's going to do to the measures we obtain. In terms of NHANES, which I know many would argue is not a surveillance system because it's not regular and systematic. The device piece, I mean, obviously, I've been involved in that and it's contributed a lot. There are no immediate plans to go back with devices. We're, as many know, we just released the data from 2011 to 14. We're still struggling with how to make sense of that and compare the wrist-worn data that we got to the previous waist-worn data. So that's still the usual kind of where are we with devices piece of it. And in terms of our other big CDC system, the BRFSS, that has had other pressures on it, and they've done quite well at just maintaining that one question of, do you engage in any physical activity, even as other questions have changed. So it's a really mixed bag in the US, I'd say, Fiona.
Look, thank you. And you already took my my next question by commenting on the actions using device-based measures. And as you pointed out, it's an opportunity, but actually what will you do with the data and making sense of it? Can I note that, thank the audience for questions coming in the Q&A. We're not going to go back into issues of setting targets nor the epi-evidence, which a couple of questions are going in, because we're really looking in this seminar at the art, science and practice of the surveillance systems we use to track against the current guidelines. And so your last question, your last slide is provocative. It's almost challenging us that as there's more we want to measure, we need to actually question that direction and see if actually measuring less but better is going to be more useful. Is that your inclination? Are you thinking it would be better to measure like a domain, as you mentioned? After all, walking and cycling have become incredibly important ways of being active, important for that agenda. Should we narrow our sights? What is your thought on it as a last remark now, but I'm sure we'll open this up again. Rick?
Yeah, I mean, I'll offer some thoughts. I don't have the answer. I mean, and I think a good answer requires a lot of further research in systems where we can look at the relationship between some of these behavioral constructs to health outcomes, where we hopefully also have, perhaps something like device-based measures. So, and at some point, NHANES will provide that opportunity. But I think, it's more an issue of, kind of, to be blunt, taking our head out of the sand and assuming we're measuring what we think we are, with the questions we're using. And just one indication of that is, there's been a few studies that have looked at changes over time using device-based measures, and they tend to find declines in, in activity, which is, doesn't surprise any of us, right? But if you look at our questionnaire results and surveillance systems, they're pretty much flat, hardly any inflections at all. And it's like, well, how can those both be true? And so that the things like that are kind of lead to asking the question, but I'm afraid I don't have the right answer for you yet. But I do want to provoke that conversation.
Well, as do I. And so with regret, I'm going to flag to Jasper, who's got one question, and then we'll move on to our next speaker. But this issue of answering that question about the consensus and which device and which cut points, we're going to be hearing from Andreas about some of that later. Jasper, you've got a question. I'd like to hand the floor to you.
Yes, thank you very much, Fiona, and thank you very much, Rick, for this this great overview and sharing with us your great experience within this. And I think my question is very much along the same lines that we've seen discussing already, and some of the questions as well. Is when we say that physical activity is hard to measure as a concept in surveys, as you were saying, well, what is it then that we can or should measure in the surveys? Do we ask people in the future have you walked today, or how many minutes have you walked today? Did you take the stairs? Is that the level of things we should be asking in the future? And if yes, should we then, the next generation of guidelines, saying 10 years from now, should it be more about certain physical activity behaviors and not physical activity as a whole? What do you think?
Well, I guess, I mean, we could talk a long time about that, but I'd say briefly, both pieces are important. I think the epidemiology, where we have strong measures, will be wanting to quantify things as much as we can. But I think we have to pay attention as well to, you know, we're not going to just do an intervention that says everybody should increase their total activity MIMS by 2,000 a day and expect that to be, you know, useful. So we have to translate it into things that people can use. And I guess what I'm coming to recognize more and more is the things that we are measuring for surveillance that we think are precise quantities are really just correlates. And so, you know, do we accept that we're measuring a quantity with a lot of error and it is correlated with what we're interested in? Or do we look for behavioral correlates that we can probably measure more precisely? And if we can establish a way to, you know, show that minutes of walking is correlated with total physical activity and has an equally strong predictive value, I think this then might be worth considering. I don't think we're ever going to go to one or the other, but I think we just need to recognize both.
Thank you very much, Rick. With that, we need to move on to our next speaker in the series. Fiona, do you want to take over again?
Thank you very much. And it's my very great pleasure to introduce a colleague, Leanne Riley, head of the unit of the NCD, Non-Communicable Disease Surveillance Unit, based in the Department of Non-Communicable Disease. Leanne has been working with NCD surveillance and the surveillance of global surveillance of physical activity for several decades and is well experienced in the systems recommended by WHO. And we've invited Leanne to join us today to present and share with the audience what exactly is the system of WHO, and you'll hear about it being called STEPS, and where does physical activity fit in. After a short presentation, we're going to invite Leanne to answer some of the questions that pick up where Rick left us, which is what's happening to the instruments of WHO. So Leanne, a very warm welcome, and I hand the floor to you to share the screen and take over.
Thank you so much, Fiona. Sorry, I'm slightly struggling to share the screen, so do let me know if it works. I know it always works when we test it, right?
And it's come up now. If you want to go to PowerPoint show, we can see your screen.
According
at the bottom.
To mine it is. How's that?
And it is now. It has come
Okay,
on.
so thank you very much, and a warm welcome on a warm sunny day in Geneva. It's my pleasure to talk to you a little bit about some of the WHO population-based physical activity surveillance systems that are trying to then address how we capture this information. And I think it flows nicely from Rick's presentation. So I wanted to talk just a little bit to position the work that we're doing to capture a lot of the information that we have about physical activity surveillance in the context of the NCD risk factor surveillance system that WHO has been operating for just over 2 decades now, and we call it STEPS. So it's the WHO supported system for NCD risk behaviours, and it captures a whole range of behaviour. So tobacco, alcohol, healthy or unhealthy diet, physical inactivity, obesity, blood pressure. I think you get the idea, but the idea from us is that by capturing a small amount of useful data about each of those topics, it helps us to track and report on the status and trends in these important health behaviours for NCDs. And physical activity has been embedded in the STEP system since it was started a couple of decades ago. So this is an adult risk factor surveillance system that targets adults aged primarily 18 to 69 in countries, but there is some wiggle room for including older adults and sometimes the 15 plus. We call it STEPS, and amazingly, that is not an acronym if you're sitting there trying to work out what those letters stand for. It's not an acronym. It really is used to describe the different levels of health assessment that's done in the survey. So step 1 is just asking a person questions about their health behaviour. And that's really at the moment where the physical activity surveillance component is captured. Step 2 then takes physical measurement, so blood pressure, height and weight to measure obesity and hypertension, for example. And these are all conducted by trained interviewers at the household level. And then step 3 is where we go a bit further, invite the person to come to a health facility where we measure their blood glucose, their lipids, and the urine for sodium, and a range of other things. And all of this data is collected on, is electronically recorded on a device to capture this. So as I mentioned, physical activity has been in STEPS since its inception, and we use the Global Physical Activity Questionnaire to do that. Since 2005, we've been using GPAC version 2. And let me just talk a little bit about what that means. So that means we include 16 questions that assess physical activity across 3 different domains. So that discussion just now has been interesting because we're looking at work-related physical activity or housework for some people, their transportation, physical activity patterns, and then there's sport and recreation. So not only are we measuring across those 3 domains, we are also trying to capture intensity of activity, so vigorous or moderate, and then the frequency and duration. So I think you start to see, and if you know that instrument well, it becomes quite a complex set of questions where we also have this bout or threshold of the 10 minutes that's important, and a question that relates to sitting. And I think we'll come back to discuss a little bit about where we see some challenges with this. So just to give the fuller picture of STEPS, we provide a lot of support to countries to implement the surveys, working with them on training, developing protocols, sampling, and so forth. Typically, a STEPS survey is around 5,000 to 6,000 adults representing the adult population in the country. And then we provide a lot of support around analysing and reporting the data that comes out of that, and then of course using it for policy and programmatic work, because that's really the bottom line. While we're interested in the trends and tracking across countries, ultimately we want data that countries can take action on and use for their work moving forward. So a little bit then just around availability. We've done these surveys now in 133 countries in the last 2 decades, always including the physical activity module of data. And we recommend that countries do these surveys about once every 5 years. I would say that the typical interval between surveys is probably a bit longer than that. Now, if you're suddenly interested that we've got all this data, we put it all in a publicly accessible microdata repository, and I've put the link to that there. We also produce guidance on how to ask the questions, how to undertake the analysis. We include all the syntax for that and a whole series of reporting tools. So that's the work that we're doing on adult risk factor surveillance and the physical activity component of that. And then my final slide, Fiona asked me to just mention a little bit of work we do around adolescent surveillance using the school-based student health survey. We call it GSHS. This is again a self-administered questionnaire, unlike the adult one where we interview someone. Students do it themselves. It's anonymous and it's confidential, because we ask about some other sensitive behaviours in the context of the questionnaire. So it's 13 to 17-year-old students in schools, and it's these 10 modules of health behaviour, and physical activity is a component of that. And we've done that in about 120 countries. So again, it's a source of data that asks around trying to capture the students' pattern of activity and whether they're meeting the current guideline of the 60 minutes per day. I think that's my last slide, Fiona. Thank you.
Thank you, Leanne. Look, tremendous, and I think the audience will really appreciate learning more about the work of WHO and that system. And just in the limited time we've got, I think there are two key questions. So I'll say both, and then you can see where we're going. I mean, we'd love to hear from you about what WHO is going to be doing. Responding to the new guidelines. So plans underway, commencing it with both particularly the adults, and then of course the last slide on the youth instruments. So what are the plans to consider the issues raised by Rick in the context of those two instruments? Let me leave it at that. What's
okay? So let me just a couple of things. Then I'd like to respond about that. We've been slightly challenged by the GPAC questions in any case, and now the new guidelines give us an opportunity to really think about them. We've struggled with these questions because of the length, there's 16 of them, so that's a bit daunting, and the repetitive nature of the questions, because it's like, do you do this moderate and then vigorous? So we would like to review the questions that we're currently asking with the idea of trying to simplify them. Removing this threshold of 10 minutes seems like an obvious choice, but also with this moderate and vigorous, when when it seems so similar and we aggregate it anyway, that maybe is something that we don't need to be doing. For us though, from a policy perspective, having the domain specific information seems to be highly relevant at the country level. So
yeah, thank you. Yeah, thank you, Leanne. And I've just popped in the chat box for the audience that paper which presented the domain data for the first time, looking at the contribution. And I think, Rick, you remarked about the different contribution of different domains across different geographies, and that's exactly what came through. So delegates can look at the chat box. Leanne, good to hear work's underway. I'm really pleased. Obviously, we'll be collaborating with you on that initiative and the scientific community to take on the challenge of updating the instruments, youth and adults. What about the wearables? And,
yes,
and WHO has been doing something, so 1 minute only.
That was my second point. Thank you very much. We've also been recognising the need to look at how we can assess self-report with device-based measurement. We've been testing objective physical activity measurement in steps, and we've undertaken pilot to see how the methods work in Malawi. We have a couple of other countries lined up, but COVID hasn't been our friend because of surveys being delayed. And we are also adding objective physical activity measurement to the global school-based student health survey, and are about to pilot that in 4 countries this year as soon as schools reopen. So it's something that we're very conscious of. And we're hoping to include that in our measures. But as the previous speaker said, we don't see it as replacing, but more supplementing and complementing the self-report. Thanks.
Thank you, Leanne. Let's pause it there. We want to bring you back into the conversation later. Jasper, back to you.
Thank you very much, Leanne, and thank you very much for Fiona for handing back. Very interesting to hear all the developments that are ongoing at WHO with the surveillance system and the testing of new tools and methods. I'm sure we're all looking forward to hearing more about that. What we would like to show you a little bit more about now is 2 speakers from the Sunrise project. That is a true worldwide collaboration looking at measuring physical activity, sedentary behavior, and also sleep in the under 5-year-olds. And we're very pleased that we have with us today Professor Tony Okely from the University of Wollongong, who is leading the Sunrise project, as well as Dr. Asmaa who is a researcher at the Joint Unit for Diet and Nutrition, CNESTEN, in Morocco. Tony and Asmaa, please, the floor is yours.
Thank you, Jasper. I'll just share my screen. Hello, it's a privilege for Asmaa, a member of our leadership group from Morocco, and I to share with you information about an international study of movement behaviours in the early years called Sunrise. In 2019, the World Health Organization released the first global guidelines for children aged birth to 5 years And these guidelines provide recommendations for physical activity, sedentary behaviour, which includes screen time and sleep, what we refer to as 24-hour movement behaviours. And the purpose of the Sunrise study is to measure the proportion of children who meet the WHO guidelines. Now, these guidelines for 3 and 4-year-old children are that a healthy 24 hours includes at least 180 minutes of physical activity, of which at least 60 minutes are moderate to vigorous in intensity, no more than 60 minutes of sedentary screen time, and 10 to 13 hours of good quality sleep. And the purpose of the Sunrise study is also to address these other study aims. And you can see from the final 2 that are in red that a focus of Sunrise is to address current gaps in the evidence in many low and middle income countries and to build capacity in this area. A key goal of the Sunrise study is to keep our ratio of low and middle income to high income countries to 2 to 1, which we are currently meeting. I'm going to hand over now to Asmaa to continue our presentation.
Thank you, Tony. Sunrise has an international leadership group with representation across all 8 United Nations SDG regions, 2 observers from the WHO, 1 advisor and statistician and data assurance expert. Move on, Tony. It's a cross-sectional study of 3 and 4 years old. Recruited from preschool setting or villages, children are eligible if they are able to wear an accelerometer. We measure physical activity, sedentary behavior, and sleep using the actigraph, one on the hip, as you can see from this video. Parents also complete a questionnaire asking about their child's screen time, their own screen behaviors, sleep quality, environmental factors that might influence movement behaviors, such as weather, pollution, traffic, noise, and safety, biodiversity, and food security. This is administered as an interview or in a group setting. Height and weight are measured using WHO protocols. We have 2 tasks from the early years toolbox that assess executive functions. Mr. Ant assesses working memory. And here is a child from Vietnam completing this task. Go no go, which assesses inhibition. And you can see in this example a child in Bangladesh participating. We have 1 fine motor skills task. And the 3 gross motor task, the one-legged balance, standing long jump, and the supine, time it up and go. We also ask centers to tell us about nap times and their policies and practices relating to movement behaviors. And I give the floor to Tony again.
Thank you very much, Asmaa. To date, we've collected pilot data in 25 countries, and the main study, which recruits a sample of 1,000 children and is designed to be broadly representative for the country, has commenced in 3 countries. To date, data have been collected on just over 2,250 children in the pilot phase and around 300 children in the main study, with roughly half from urban and rural areas. And unfortunately, COVID has resulted in the suspension of or delay in data collection in many countries, especially 2 of those that had commenced the main study. Now, in this figure, we've shaded an entire country to show the proportion from the convenient sampled sites within that country. And they are in no way meant to represent the entire country or even a region in that country because of those reasons. It's just designed to make the findings easier to display and interpret for this presentation. So data collected so far from the sites in the pilot study show considerable variability across the sites in the proportion of children who meet all recommendations of the guidelines. And we've also found that children from the data collection sites in high-income countries were more likely to meet the MVPA and the sleep recommendations of the guidelines than their peers from sites in low and middle-income countries. If you would like to know more about the study, and particularly if you're from a low or middle-income country and are interested in being involved, you can follow us on Twitter or YouTube. And I'd like to thank our coordinating team at the University of Wollongong for all their work preparing the data and supporting countries, and for all the countries that are involved, especially those who are watching today. And I'd like to thank each of the countries involved, especially the CIs and their teams. Here's our study website if you'd like to find out more, and you can also contact us via email. Thank you.
Thank you very much, Tony and Asmaa, for this great overview of the Sunrise study. And it's amazing to see all these very innovative measures that you have come up with to measure behavior for this age group. One of the things that I was wondering about, you were talking about the pilot study and the main study. When is the main study, or when are more countries going to join the main study? And yeah, how does it work if there are other people attending here that are interested in contributing to the study? What do they do? How does that work?
Sure. So the main barrier to implementing the main study so far in countries has been funding. However, countries have been able to resource it within their own means. So we have a country like Papua New Guinea, which have been able to integrate the study into an existing surveillance system. In Malaysia, they have recruited teams of researchers from around the country from different regions who are collaborating to be able to conduct the study there. And in Sweden, there is also similar collaborations occurring. And we are seeing that happening in other countries that are planning for the main study as well. For countries to be involved, what we do is we ask them to contact us via the email address. And in particular, we're looking to recruit, to keep that ratio of low and middle to high income countries to 2 to 1. So for every 2 low or middle income countries we recruit, then we look at opening it up to another high income country. So you will see from the map that we presented that there are a number of, we'd like to have some more countries, particularly from Africa and from Latin America. So if there are people on the call that are interested, please feel free to get in touch.
Thank you very much. I would also like to open the floor again for more questions to Leanne, if there are any that haven't been answered yet. As you might have seen in the Q&A box, the panelists have been very good in answering questions there as well. But feel free to put in new questions there.
Jasper, I would
yes, go
like
ahead,
to
Fiona.
step in if there's time for one more question. Tony, can you tell us a little more about the experience with the device? Obviously, the size of it, the use of it, the loss of it, the acceptability. These are unfamiliar to be used in this age group. Can you expand a little bit more on how acceptable you found them, how feasible, and whether indeed there's any need for innovation in the technology to adapt it for this age group? Thank you, Tony.
Sure. I'll begin, and then I might hand over to Asmaa after I finish, so that they're actually just finishing data collection in Morocco now, so she'll be able to give some experience from the data collection team in Morocco. Look, it hasn't been without its challenges. The Actigraph, we do find that we try and get 3 full days of monitoring. That's been a challenge in a number of countries for a range of reasons, and we're constantly surprised by the reasons. Fiona, data collection is happening in Nigeria at the moment, and we had within the first data collection site, there were a number of children who didn't wear it, and when we asked the data collection team there, they mentioned that there was a security concern, and we asked what that meant, because we've come across this before, particularly if the monitors are being worn on the wrist and they're visible. But these were monitors that were being worn under the clothes. And they said, look, in some parts of the country where unfortunately children are kidnapped from schools, parents thought that this device was somehow enable the children to be tracked. So they didn't want the children to wear them. So again, it's sort of part of educating parents that they're not designed to do that. We tend to find with the Actigraph, the size of it at the moment, that it's hard for children to wear at night, and when they're sleeping, that's when they tend to take it off. So that's been the biggest challenge for us with that. During the day, it seems to be okay. In some countries where the children, don't wear a lot of clothing and it can be seen and can be visible, there's the additional challenge of it being taken by older children, or even just drawing attention to those children. So there's some of the biggest challenges that we've had with it at the moment. But nonetheless, we've experimented with different devices, and this seems to be the one that works best. Asmaa, did you want to add anything from Morocco in terms of your experience with the Actigraph?
Just very quickly, we'd love to hear from you, Asmaa.
Okay, very quickly. In general, the Actigraph was very acceptable by children. Boys call it the power belt. And they were very sad to when we asked them to remove it. But as Tony said, some found it uncomfortable during sleep.
Very interesting, and clearly I think it's suggesting that there needs to be potential for some innovation around the device. But look, that's excellent to hear about this research. I hand back to Jasper.
Thank you very much, Tony and Asmaa, for your introduction to this age group. There were a few questions popping in the Q&A. I hope you will be able to answer as well. And I think this last point also brings us with a very nice link to the next presentation from Andreas Holtermann, Professor Andreas Holtermann, who works at the National Research Center for the Working Environment in Copenhagen, Denmark. And he will perhaps tell us a little bit more about something that hopefully could also be very useful in the future of the Sunrise study. Andreas, the floor is yours.
Thank you, Jasper. It's a privilege to be permitted to present here. I've been looking forward to it. So I will not give any detailed information about algorithms, about placements, about all these technicalities. I will tell more about a vision, a dream we have with respect to be able to do surveillance of meaningful physical activity for all. We have actually from the health authority in Denmark, but from the occupational health authority, we actually got funding to develop a surveillance system, which we call SURPASS, to monitoring physical activity, sedentary behavior, and sleep, and which should be feasible to be implemented both in occupational surveillance and in public health surveillance. And this is a close collaboration with the ProPass society, which many of you know, which is about prospective harmonization of physical activity and physical behaviors. Wow. So let's see if I can change the slides. There you go. So the vision of this surveillance system, device-based surveillance system, is to have meaningful 24/7 information about physical behaviors for all. And what I mean by that is that it should not only be in high-income countries, high socioeconomic groups, but it should be in those countries having the poorest resources and having large fractions of the population with lower socioeconomic background. And what do you think are the most important technicalities to develop to be able to do that? We think that the most important things are related to having a system which puts minimal burden on the participant. It should be very, very easy to use and require very little, for instance, of the participant to come into a facility or something like that. But it should also be very, very low burden on the admin people, the staff who are running this. And often when I ask different researchers running different surveillance and cohorts and ask them about what is the cost of running this surveillance, then they often say, well, the cost of this accelerometer is that, and we have used so and that, this and that much of money on that, without saying, well, we required 3 years of resources to setting up, with experts setting up these devices, and 2 to 3 years to analyze the data and harmonize it with other studies afterwards. So it needs to be low burden, both for the participant and for the admin. And then I think one of the most important things is that it needs to be an easy data flow with a high security. Up to now, we have been focusing a lot on the details about algorithms and the size of accelerometers and where to place it, but it become more and more clear, particularly in Europe, but also other places in the world, that data regulations and security is crucial. So if we should be able to develop a system like this, which should be used in lower and middle income countries, it needs to be very, very easy to comply with the data security and regulations. And in the end, it needs to be flexible and scalable. So we are able to, in a smart way, easy way, to compare, to harmonize, to merge data and information. So I think we should go from having a much focus on different accelerometer brands, where to place them on the body, which algorithms to use, validation of them, and measurements of scale, just because it's a scale and not being representative of a population, towards going more towards having a very, very low cost, low burden measurement system, which is efficient, hygiene friendly, and very good logistic solutions, which is crucial, I think, for being able to manage these type of devices and analysis in low and middle income countries. It also needs to be ease, data harmonization, data flow, and security. And in the end, I think we need to have federated, fully automated analysis of these type of physical behaviors. What do I mean by meaningful physical behaviors? We have been into it before. I think I'm talking about behaviors which people normally do. When you sit, when you stand, when you walk, cycling and so on, both at work, transport, leisure, but also sleep. And from this, you can afterwards, you can pull out the information about intensity, duration, frequency, and so on. But I think these are the crucial information which in my opinion, we should base these type of measurements on. The system we are developing currently is based on a very cheap disposable accelerometer, which can be placed on the thigh. The plan is to send it out by mail, so post it out to the participants. Participants put them on the thigh. They download the app. Then the data is going from the accelerometer by Bluetooth to the mobile phone, sending it further up to the cloud, and all by twice security level to be able to apply for the GDPR regulations, so the data protection regulations in Europe and other places in the world. Then the data is analyzed, fully automatic, and can be then given back to the participants, and in a meaningful way, giving information about what the person is doing, but also being brought back to the admin, which then could do the fully automatic analysis and have the data ready for being shared, compared within days with other countries. This is the dream. This is the vision. So in this way, we think that it's just so important to work on these different characteristics for having a minimal burden on the participants and minimal burden on the admin staff. I will not go into all this. I don't have time for it. But then I also think we need to have so much more focus on developing secure systems for being able to handle this massive amount of data in a fully automatic, secure manner, from the accelerometer and all the way through to having the data harmonized and used by WHO and other institutions directly. What we are working on currently is to have a solution which is cloud-based, fully compliant to data regulations. So in general, if a country are doing all these different previous steps, which I mentioned, then you will have the data available in the cloud, which then can be analyzed fully automatic, and which is already harmonized and can then be shared and analyzed and used by, for instance, WHO or other institutes directly. You don't have to, bring the data across borders and so on. So this was a really quick intro to the system, to our vision, and what we think is required to be able to have device-based measurements of meaningful physical behaviors for all. And we are having an extensive collaboration with a company called Sense Innovation. It's the research group in Copenhagen, which is led by Nidhi Gupta. And then we have a really good scientific advisory board, which are providing us with a lot of help and guidance in this. Thank you.
Thank you so much, Andreas, for this thought-provoking dream. And I think one of the questions that it's probably on everyone's mind, or at least it is on my mind right now, is this dream going to be reality? And when can we buy this, or when can we use this?
Yeah, good question. So in principle, the accelerometer is developed. The system for sending the data from a device to the mobile phone up to the sky, fully secured, it exists. We are now about to develop the mobile phone app for this. So we are actually, next week, we are doing feasibility studies on it. And what we are also working a lot is about the complete, fully automated analysis. I think that's crucial, because it's so few countries in the world having experts and resources to do analysis on this. So that's another thing which we are working on. So we hope, I cannot promise anything, but we hope within a year or so that it should be feasible to have a system which is usable. That is a question, if it's already there, which it can be used for tracking physical behaviors for WHO or something like that. I think that will take some more time, but at least in I think for some countries to start out small, I think we'll be ready quite soon.
Thank you, Andreas. I can see, Fiona, you raised your hand.
Yes, a privilege of being on this side of the table, but perhaps others are also thinking this. It's a wonderful vision and lots of the attributes we absolutely share, but there's a step in the middle there, which is the mobile phone. Is that step necessary? That requires individuals to have a phone. Why can't the device record the data and you bypass the phone with all the complexity, security, cost, and variability that will have, Andreas?
Yeah, that's feasible. The accelerometer, which now is available, can measure data for, I think it's 3 weeks. So yeah, it's no problem whatsoever. The issue is that then they have to bring the accelerometer back somehow, right? That's feasible, but we also know that that can be a burden on the participants. The other thing is that we think that is so important, not only for having the information, but also when you want to go back to policy and practice, it's so important to know if it's during work or if it's during leisure. As you know, it's very different things you can advise and the way to go about if you want to change what people are doing at work compared to leisure. So this is a crucial point, but we're also working on that. I think it would be really important if we could be able to analyze if a person is at work or not by axiometry. But so
presumably you're wanting to use the GPS of the phone to know the location. How are you getting work from an accelerometry device? It must be data from the phone or some assumptions.
Yes. So based on the app on the phone, there is a diary. So they are just So it's just self-report when they are going to work and when they are going off work. So that's diary based. Then we have a lot of discussions currently with it's with the unions, the work unions, because they are very critical to have the GPS data. So that's another thing which we are also. But it's also, it's a lot of people not working at the same, not having at the same workplace, physical workplace, right? They are being everywhere working. So it's really hard to extract that. Yeah, so it's after now, that's one of the key elements of the app is to have the diary.
So it sounds a little bit more than device only, to be honest. It's device, app, phone, diary. Quite complicated.
Yeah, but I think in general, it should be device, it should be download app, and it should be when you start to work and when you end work. But I think it's as crucial elements if this is too complex. And that is what we are currently testing. And perhaps it might be a better solution to skip the app. But then, of course, also it will be some information which will be lost if you are not having this diary.
Thank you for your answers. Let me hand back to Jasper, who might be looking on the Q&A. Jasper.
I'm both looking on the Q&A, but I'm also seeing a raised hand from Rick. And obviously the panelists are using or misusing their function here. But I think, Rick, I'll allow you to ask a question here as well.
Thank you, Jasper. I tried to type it in the Q&A, but I could only see ways to answer. I couldn't see a way to ask a question. But to the discussion that just happened, I just wanted to raise the point that what we have left out, and certainly I left out, between self-report in the traditional manner and device-based measures is kind of what Andreas and Fiona were discussing, which is more EMA, ecological momentary assessment, to have some kind of device on the phone in an app to allow people to report in real time what they're doing. At one point, some years ago, we tried to develop that where you could just add, people could customize it to say, what are their, most common physical activities? And they could just hit a button and it would start timing it, and they could hit another button and stop it. And for lots of technical reasons, that didn't work out. But that's just a different approach that we really haven't talked about much today, and I wanted to not leave that out totally.
I think it's a really, really good point, Rick. I think at least in my perspective, I think we are going more and more further towards the importance of domain, the importance of environment. So I think it will be really good to have that possibility also embedded in the system. But we are not currently developing it.
Can I pick up on that? Because it flows from the questions asked of Rick and Leanne picked up on, which was this interest in the domain. And so you're thinking the domain is a priority area to retain. After all, you can lose it if you just have a pedometer count. You have one piece of information. Accelerometers add to that, but again, miss out what you're doing. So you say domain, and could you comment on that if I'm right in what you're saying? It's a priority. And then you say environment. Now, what do you mean? Is that where people are doing it, or is that other environmental attributes, context, or others? Back to you.
Love the question. Well, you know, I'm coming from occupational health, and in occupational health, it's always been, you know, this different paradigm about what you're doing at work is of less control, particularly among lower socioeconomic groups, right? So it's been long time known that independent of the health effects of physical activity, that's also a long discussion. But if you want to change physical activity, let's say it's a manufacturing worker, a construction worker, then it's not to go out to the worker and motivate or provide knowledge, it's to go to the manager, right? To be able to change the environment. And I think that's a really important when we are trying to go further towards low and middle income countries where more are having manual tasks. It's daily tasks they're doing. And also respect to lower socioeconomic groups, also in Scandinavia and other Western countries, right? Where it's not only about, you know, the normal, what we're saying, do you have green parks and cycling lanes and all these wonderful things you have in Copenhagen, right? But more about, is the behavior are you doing it because you have to get paid? Or are you doing it because you want to promote your well-being and health? And how much can you influence it yourself?
Well, you've expanded it even further there, and I'm now haunted by Rick, who might join the conversation here. You concluded that maybe we should be measuring less and better, but we're being taken into measuring why I'm doing it and how I feel about it, where I'm doing it, not only the intensity, duration, and the momentary. This is getting into the realms of quite sophisticated and complicated. And we've got a tension, this tug of war. Simplicity, usable data to track for national governments. And I remind that Leanne, and that's the WHO's goal, is to support countries, measure something that's usable in this behavior called physical activity. When do we step over and we're into a different domain or different purpose? Andrea, maybe you have a reaction. I'd love to hear Rick.
Well, I think Andrea put it clearly. He has played his cards. He said he's coming from an occupational health perspective, and I think that's, you know, we have to decide what we care about, what our question is, and then we can figure out how to measure it. And I think our challenge has been, we've been trying to measure everything for everything, and that's hard.
Well, Andreas, do have an answer, and then I want to pick up on a question that's come in the Q&A about measuring walking, because you're quite right, Rick. Different people have an interest, and there's a big interest in measuring walking and cycling and separately. But Andreas, any reply on this? You have played your cards.
I think these discussions are so crucial because it's coming, the technological developments are going so rapid. What we can do to just 5 years from now is it's so much, right? But we just have to have these type of discussion to make sure that we are still measuring the important things and still be able, for surveillance and for whatnot, be able to track what people are doing. And but that, I think that's really the hard thing, and that's why I think it's so good that this community are having this dialogue, because we need to find this way, right? So we're not just getting out of space, way far away from what we really can give guidance upon, because just the technology permits it, right?
Very good points. I'm looking, Jasper, to see if there's questions coming in the Q&A, and I'm also looking at other panel members who might like to join with their their screens. I mean, the challenge here is what do we want to measure, and it depends where you are sitting as to what is your priority. And I'd like to pick up that walking and cycling. Leanne, you introduced that the domain is there in the GPAC, and many of the audience will be aware it's there in other instruments, and notably IPAC. It's a combined measure of walking and cycling in GPAC. And interestingly, the GPAC data set across all countries is one of the largest on the behaviour of walking and cycling active travel, but it falls short of what we want. So we have another purpose to measure active travel. We promote it, and yet we don't have a good alignment with a surveillance instrument. Would any of the panelists like to offer a comment on that, a way forward on that? And I'm looking to see if Leanne's available to any comment as well.
Yeah, Fiona, I am here, and I would like to comment. I mean, our experience with the countries is that the domain is particularly important, because there may be aspects of the person's life that they're not able to influence by policy measures. But so knowing what the domain that drives the physical activity patterns in different age groups and the differences between men and women is really critical for policy level information. And so I think to lose that would be a real shame. And I think, in fact, the trend is to push us to do more disaggregated, as you say, walking separate from cycling, because they require slightly different policy and programmatic responses. And I see that's the sort of thing that we want to start thinking about with the current instrument, and whether we can differentiate some of those things, but it has to be policy relevant. I want to keep stressing that. Yeah,
you raised that, and the audience would no doubt be interested in the UN, the WHO Decade of Action on Road Safety, which is renewed. This is a second decade of action, and the agenda is modal shift, and a focus on increasing walking and cycling and non-motorized transport for all the reasons that are very clear to us in the context of climate action. And so having good data. So this brings our colleagues in transport to the table as well as occupation. Again, I draw the audience to the paper, but led by Tessa Strain and colleagues that analysed this and showed that for most middle and low income countries, it was occupational and transport that's the largest domain. We probably knew that anyway, but the data now show it. And that's important, because we know data influences policy. It informs and provides objective debate rather than anecdotal, which is useful in the political and policy making. I'm looking at Jasper. Do you see some questions? Over to you.
I do see some questions as well, but I was misusing my panelist privilege here, and going to make a comment saying that if we look at this domain-specific data also in higher income countries, we actually see similar patterns that for most people, their main physical activity is either work-related or transport-related as well. Leisure time is a relatively small domain for a lot of people in a lot of countries, surprisingly, yet a lot of our survey measures are very focused on that. So there's a lot of work to be done there. I see a question, quite a practical question, coming in, sort of the importance of measuring these separate behaviors, the dropping the bouts. What are the panel's view on that moving forward? Do we need to change anything in our surveillance systems now that we have dropped the bouts, but potentially looking more at specific behaviors? And I think that's sort of the last chance you have to say something before we have to round up in a few minutes.
Well, I can jump in along with Leanne to just reaffirm that WHO will be looking at those needs, exactly those needs, in relation to the global instruments, and we hope that that technical advice that would come out could inform their national instruments. It will clearly need to be guided by a continuation of this kind of debate, and the input that we can learn from many countries. But change of instruments does look like it will happen, or analytical processing of the data. But at the moment, consensus on what to change is a process we're now starting with the new guidelines from WHO. I see Rick has got also a reaction.
Just a comment. I mean, I think there's no question that, if the questions need to change, because your purpose of the questions is to monitor the guidelines, and the guidelines change. So that's a given. But I guess my point would be, it's also an opportunity for the research community to collaborate with WHO and try and do some methodologic research and say, if you can't do a bridging study in a national survey, you can certainly do some smaller focus group testing or just smaller measurements where you can see how changing the question changes the answers. And that's right now, that's a huge unknown for us. I mean, we know the bouts went away, but we don't know what taking the bouts away from the measures is gonna do and mean.
Thank you, Rick. Very, very practical about how collaboration between the science community, governments doing surveillance, and WHO to answer these questions. And of course, the Guideline Development Committee did identify these challenges for global surveillance. And so we did have a research paper, that research priorities paper, which we might be able to put into the chat box, a link. But message heard there, Rick, and a very valuable comment. Let me hand back to Jasper.
Yes, and I can see there are a lot of our panelists that would like to say more. There is a lot more to be said on this topic, but unfortunately our time is running out, and I'm sure this is a discussion and a debate that will continue at all the online and hopefully in not too distant future real conferences in our field as well. Last word is definitely not said yet. So what I would like to do before ending is thanking you all for being here, participating in our webinar. The next webinar will be in September. More information is to follow on what and where exactly, but there are very good webinars coming up. Fiona, would you like to say a few words?
Thank you very much, Rick, Jasper, and thank you very much to Rick and all of the panelists, of course. As we draw this webinar to a close, and I'll make a few remarks about it, it's timely to let you know of some concurrent webinars that are underway. And showing here is the overarching invitation to you to participate in the Reinvent and Rebuild webinar series WHO has embarked on in response to the impact of COVID onto the physical activity agenda. It's a series of 8 webinars, and all the information was on the previous slide, but we have just jumped, and you can get and sign up for information. Thank you, Wana. And when we look at the forthcoming, we're holding them weekly. And the next Thursday, the 3rd of this series of 8, we'll be looking at evidence again. And we're looking at the evidence of physical activity in COVID with some researchers you can see there listed, sharing the latest published science and debating how that evidence can inform policy. Do join us. They're free, they're recorded. And so connecting with us on the Reinvent webinar series. Let me make my final remarks to thank again all of you joining this webinar series. WHO is delighted to work with ISPAH to extend the communication and dissemination and the discussion about the implications of new guidelines. And this has met my expectations and exceeded them with some excellent presentations. So thank you to all the panelists for sharing your time and your knowledge and insights. It's a wonderful point where we've got the challenges and opportunities to improve what we're doing, but we have got the difficulties of these competing needs of what we're measuring for what purpose and then what tool to use. So I look forward to us going forward with this discussion and seeing how we can help guide and be informed by others in this field. It's been a real pleasure to have Rick Troiano join us, because at the outset, we were aware that this is quite an important moment, as Rick will be transitioning after a 28-year career in physical activity. So we'd like to extend our great wishes to you, Rick. Thank you for joining us.
Thank you.
Thank you very much, Fiona. Thank you very much to all our panelists. And as we just heard, this is very much a webinar series about raising the discussion. We're not here to tell you how it is exactly, what the best science is. We're here to have the discussion about what is going to be happen next. What are the topics that we need to discuss? So please let us know what you thought about this webinar, what we can improve for the future. And if you're interested in hearing more, following along with what ISPAH is doing, sign up for our newsletter or consider becoming a member. Thank you very much for joining this webinar, and the recordings will be available next week on the ISPAH website. Thank you once again. Thank you to all our panelists and to all our participants. It was a pleasure.